Dear doctors, I hope you are doing well with your MRChem intermediate preparation. I am Dr. Mohammad Belal Hussain from Medino Academy, and I am a candidate of MRChem UK OSCE, MRCP UK PACES, and MRCP General Medicine Part 2 clinical exam. And our today's topic is ECG in emergency medicine for MRChem intermediate. You all know that ECG is very much important for passing MRChem intermediate exam and also for our clinical practice. So let's go for our today's topic. This image represents the normal ECG components. This is the P wave, QRS complex, T wave, and U wave. This is the period interval. It represents the time interval between the onset of P wave up to the onset of QRS complex. This is QT interval. It represents the time interval between the onset of QRS complex up to the end of the T wave. There are two segments, PR segment and ST segment. PR segment represents the ECG segments between the end of the P wave and the onset of the QRS complex. And ST segment represents the ECG segments from J point up to the onset of T wave. The normal pure interval is 0.1 to 2.20 seconds. That means from 3 small squares to 5 small squares. Now, the wave abnormalities. There are some P wave abnormalities like absent P wave, tall peak T, white P wave, and inverted P wave. Absent P wave may be found in case of atrial fibrillation. Tall peak T, that is also called P pulmonale, can be found in case of COPD or pulmonary hypertension. That means in case of right atrial hypertrophy. And white P wave, that means P mitrally, can be found in case of left atrial hypertrophy in mitral stenosis. And inverted P wave may be found in incorrect lead placement, dextrocardia, or nodal rhythm with retrograde conduction. This is the tall peak T, that means P pulmonale, where the length of the P wave is more than 2.5 small squares, and this is the wide P, that means P mitrally. In this case, the width of the P is more than 2.5 small squares. Now, the pathological Q. Q wave is pathological when the depth of the P is more than 2 millimeter or more than 2 small square. PR interval abnormalities. PR interval is prolonged when it is more than 5 small square or more than zero point 0.2 second, and it may be found in case of first degree heart block or ISD, and due to some drugs like digoxin or verapamil. Short PR interval is called when the PR interval is less than 3 small squares. It can be present in WPW syndrome or LGL syndrome. The QRS complex abnormalities, high voltage QRS or low voltage QRS, or QRS complex may be wide, that means more than 3 small squares. High voltage QRS complex can be found in ventricular hypertrophy, and low voltage ECG can be found in pericardial effusion or chronic constrictive pericarditis or in case of obesity. And white QRS complex, that means the width of the QRS complex is more than 3 small squares. It can be found in case of bundle branch block like left or right bundle branch blocks, or in case of hyperkalemia, or in case of VT. ST segment elevation. ST segment is elevated when the elevation is more than 2 millimeter in case of chest leads and more than 1 millimeter in case of limb leads. It may be found in case of myocardial infarction, pericarditis, etc. And ST depression may be found in case of myocardial ischemia, ventricular hypertrophy strain pattern, or digoxin toxicity. TOF abnormalities, inverted TOF and tall peak TOF. Inverted TOF is this inverted TOF may be found in case of myocardial ischemia or infarction, and tall peak T can be present in case of hyperkalemia. U wave. Prominent U wave can be found in hypokalemia or hypercalcemia. QT interval. We have already discussed about the QT interval. You can see the QT interval represents the time interval between the onset of the QRS complex up to the end of the T wave. And this QT interval is variable with heart rate, and it is inversely proportional. When the heart rate increases, QT interval decreases, and when the heart rate decreases, QT interval is increased. So, due to this variability, we can calculate corrected QT interval by this formula. The normal QT interval is less than 440 millisecond in case of men and less than 460 millisecond in case of women. Now the axis deviation. When there is positive deflection in case of lead 1 and also positive deflection in case of lead 2, 3 or AVF, this is the normal axis. When in lead 1 it is positive and in lead AVF or 2 or 3 it is negative, this is called positive. This is called left axis deviation. When the lead 1 shows negative deflection and lead AVF shows positive deflection, this is called right axis deviation. When both is negative, it is called extreme axis deviation. We can see in this picture, in the first image, we can see that in lead 1 there is negative deflection and 2, 3 AVF shows positive deflection. So this is right axis deviation. And in case of left axis deviation, there is positive deflection in lead 1 and negative deflection in lead 2, 3 or AVF. When both is positive, that means positive in lead 1 and positive in lead AVF, this is normal axis. When both are negative, that means negative in lead 1 and negative in lead AVF, it represents extreme axis deviation. Right ventricular hypertrophy ECG findings includes right axis deviation and dominant R wave in V1. That means R wave in V1 is less than 7 small square, and dominant S wave in V5 or V6, that means more than 7 small square. The depth of the S wave is more than 7 small square in V5 or V6. Now we can see the right ventricular hypertrophy ECG. This is the dominant R wave in V1. R wave is obviously less than 7 small square here. And left ventricular hypertrophy, the ECG findings is left axis deviation. There is a criteria which is called Vortex criteria for LVH. That means the summation of S wave in V1 and R wave in V5 or V6 should be more than 35 millimeter or more than 35 small square, and R wave in AVL more than 11 millimeter or 11 small square. We can see that S wave in V1 and R wave in V5 or V6, the summation of these more than 35. So this is a case of left ventricular hypertrophy. Or in case of AVL, the R wave may be more than 11. These 11 small squares, these also represents left ventricular hypertrophy. Now right bundle branch block and left bundle branch block. There is a easy and popular mnemonic for right and left bundle branch block, that is Marrow and William. Marrow in case of RBBB, that means M shape in V1 and or V2, and W shape in V5 or V6 represents right bundle branch block. But when W shape in V1 and V2 and M shape in V5 or V6, it represents left bundle branch block. We can see the ECG for this one. mm, there is M pattern in the V1 and V2. So M pattern in V1 and V2 represents right bundle branch block, and in this ECG we can appreciate uh, M pattern in V6. So it represents left bundle branch block. Bifascicular block, we can see in this image there are two fascicles. Sorry, there are three fascicles. That means right bundle branch, left bundle branch, which is divided further into two fascicles, or like left anterior fascicle and left posterior fascicle. What is bifascicular block? Bifascicular block means RBBB plus either a left anterior fascicular block or left posterior fascicular block. When RBBB is associated with left anterior fascicular block, left anterior fascicular block, in, which is represented by left axis deviation. This is one type of bifascicular block. Another type of bifascicular block is combination of RBBB with left posterior fascicular block, which is represented by right axis deviation. That means the left anterior fascicular block is represented by left axis deviation, and left posterior fascicular block is represented by right axis deviation. So there is two bundle branch, right bundle branch and left bundle branch. Left bundle branch is further divided into left anterior fascicle and left posterior fascicle. Bifascicular block represents the combination of either RBBB plus left anterior fascicular block or RBBB plus left posterior fascicular block. Left anterior fascicular block represents left axis deviation, but left posterior uh, fascicular block represents right axis deviation. This is the ECG of RBBB plus left anterior fascicular block. You can appreciate M pattern in case of V1 and V2. That means there is RBBB and left anterior fascicular block is appreciated by AD. You can see positive deflection in case of lead 1 and negative deflection in case of AVF. Now RBBB plus left posterior fascicular block, it is another what's possible combination of bifascicular block. Here you can appreciate M pattern in V1 that represents RBBB and left posterior fascicular block, which is represented by right axis deviation. You can see negative deflection in case of lead 1 and positive deflection in case of AVF. So there is right axis deviation, which is represented by, which is caused by left posterior fascicular block and also RBBB. Trifascicular block. Trifascicular block may be incomplete or complete. Incomplete means bifascicular block plus first or second degree heart block, AV block, or complete trifascicular block. That means bifascicular block plus complete AV block or third degree heart block. We will discuss this. We will discuss later about atrioventricular block. This is the incomplete trifascicular block. Incomplete trifascicular block is a combination of RBBB plus first degree heart block or second degree heart block. This is the M pattern in the V1 or V2. So there is RBBB plus, you can appreciate there is a prolonged peer interval. That means there is first degree heart block. So this is incomplete trifascicular block. And in this picture, we can see complete trifascicular block. That means RBBB, bifascicular block plus complete heart block. You can see there is RBBB, that means M pattern in V1, positive deflection in lead 1 and negative deflection in AVF, which represents left axis deviation. So RBBB plus left axis deviation is bifascicular block, plus there is also a complete heart block. In this rhythm, you can appreciate complete heart block. That means P interval is constant, and RR interval also constant, but PR interval is variable. That means there is no association between the POF and the QRS complexes. So it is called complete heart block. So what is the combination of these findings? There is RBBB, LAD, and complete heart blocks. So this is complete trifascicular block. Now the ECG of MI. ECG criteria for thrombolysis or primary PCI referral. Number one, new onset LBBB, then ST segment elevation, that we have already discussed about that. More than 2 small square in chest leads, more than 1 small square in 2 contiguous limb leads. Okay, so more than 2 small square in chest leads and more than 1 small square in limb leads. And there is another condition. Uh, this should be present in 2 contiguous leads. Now you can see image. It represents the culprit artery and the anatomical location of MI in ECG. In case of lateral myocardial infarction, you can appreciate ST elevation in case of lead 1, lead AVL, and V5 and V6. In case of inferior MI, ST elevation uh, is ST elevation can be found in case of lead 2, 3, and lead AVF. In case of septal MI, ST elevation may be found in case of V1 and V2. And in case of anterior MI, ST elevation may be found in case of V3 and V4. When we found ST elevation in V1, V2, V3, and V4, it is called anteroseptal. And when anterior leads and also 1 and AVL shows ST elevation, it is called extensive anterior. This is extensive anterior or anterolateral. Inferior MI may be involved with right ventricular infarction or posterior infarction. Now there are some ECGs of STMI. First of all, we can see the ECG of inferior MI. That means ST elevation in 2, 3, and AVF. This is the ST elevation in 2, 3, and AVF. So this is the ECG of inferior ST elevation MI. We have already mentioned that inferior MI may be involved with right ventricular infarction. So this ECG represents right ventricular infarction. There is ST elevation in lead 2 and lead 3 and lead AVF, but mm, ST is more elevated in lead 3 than lead 2. It represents right ventricular infarction. Now the anterior STMI, you can see the ST elevation in case of V2, V3, V4, and also V5. So this is anterior STMI. Now the extensive anterior STMI, there is ST elevation in anterior leads. That means V2, V3, V4, and V5 with ST elevation in lead 1 and lead AVL. Lead 1 and lead AVL. So this is extensive anterior STMI. Now, Wallen syndrome. Wallen syndrome is of two types, type A pattern and type B pattern. Type A pattern represents biphasic TOFs in V2 and V3. This is the biphasic T, that means T wave has a positive deflection, also followed by a negative deflection. This is called biphasic T waves. So in type A pattern of Wallen syndrome, there is biphasic T waves in lead V2 and lead V3. In case of Wallen syndrome type B, there are deep symmetrical T waves. These are the deep and symmetrical T waves. Deep and symmetrical T waves. There is no positive deflection. So this is not biphasic. This is deep and symmetrical T waves in V2 and V3. This is called Wallen type B. And what is the significance of this type of ECG? These biphasic T waves or deep symmetrical T waves um, is highly specific for critical stenosis of the LAD, that means left anterior descending artery. So it represents critical stenosis of the LAD. Now the de-Winter TOFs, you can see the de-Winter TOFs here in this ECG. What is de-Winter TOFs? It is the upsloping ST depression in the precordial leads more than 1 millimeter. So this is the ST depression, upsloping ST depression. This is the upsloping ST depression more than 1 millimeter. So this is called this is also upsloping ST depression, upsloping ST depression more than 1 millimeter. It is called de-Winter TOFs. De-Winter TOFs also indicates the critical stenosis of LAD. Now the lateral MI. This is the anterolateral MI. That means there is ST elevation in the V2, V3, V4, V5, and also V6. So this is anterolateral. There is also ST elevation in lead 1 and lead AVL. So there is anterior wall ST elevation and also lateral wall ST elevation. Lateral wall ST elevation. So the summation is anterolateral ST elevated MI. Inferior posterior lateral STMI. So where is the ST elevation? In lead 2, 3, and AVF. So inferior posterior ST elevation is represented by this ST depression and upright R in case of V1 and V2. So the posterior infarction is represented by ST depression in V1 and V2 and upright R wave in case of V1 and V2. and lateral MI is represented here by ST elevation in lead V5 and V6. Lead V5 and V6. So this is inferior posterior lateral STMI. Now isolated lateral infarction, that means uh, ST elevation is present only in lead 1, lead AVL, V5 and V6. Lead 1, AVL, V5 and V6. So this is isolated lateral infarction. High lateral STMI is represented by ST elevation in lead 1 and lead AVL. There is no ST elevation in lead V5 and V6. So when there is ST elevation in lead 1, AVL, V5 and V6, it is isolated lateral infarction. And when there is ST elevation in case of only lead 1 and AVL, no ST elevation in V5 and V6, it is called high lateral ST elevation MI. Now, what is Garbosa criteria? When we use this criteria, we have already discussed that the ECG criteria for PCI number 1 is new onset LBBB. So how can we differentiate new onset LBBB or previously um, previous LBBB? Here comes Garbosa criteria. Now, in Garbosa criteria, there is 3 points: number 1, 2, and 3. First point indicates concordant ST elevation more than 1 millimeter in leads with a positive QRS complex. It represents a score 5. Look at this number 1 picture. There is QRS complex that is positive. That means positive QRS complex. And at the same side, there is ST elevation. So positive QRS complex when the ST elevation present uh, at the same site of the QRS complex, it is called concordant. Where the ST elevation presents opposite side of the QRS complex, it is called discordant. In this first image, number 1, we can see the ST elevation presents at the same side of the QRS complex. So this is concordant ST elevation, obviously more than 1 millimeter, and with a positive QRS complex. So it represents a score 5. Number 2, concordant ST concordant ST depression. This is number 2, concordant ST depression. That means this is the QRS complex. This is the QRS complex, and ST depression presents also at the same side of the QRS complex. This is the isoelectric line. This is the isoelectric line, and ST depression is present at the same side of the QRS complex. So it is concordant ST depression more than 1 millimeter, obviously more than 1 millimeter here. So this is the second point, and it represents score 3. And point number 3, you can see the number 3 ECG pattern, discordant ST elevation. This is discordant. Where is discordant? You can see the isoelectric line here. The red mark is isoelectric line. QRS complex is negative, but ST depression is in case of positive deflection. So ST depression, ST elevation is ST elevation is on the opposite side of the QRS complex, so it is discordant. So discordant ST elevation more than 5 millimeter. This is the third point, and it represents score 2. When uh, The score is total score in an ECG is more than 3. It is a higher specificity of 90% for diagnosis of myocardial infarction. When we found a LBBB in an ECG, we should calculate this Garbosa criteria points. When there is more than or equal 3 points, it is specific for diagnosis of myocardial infarction, and we can send the patient to cath lab for PCI, or or we can thrombolize the patient. Now, subendocardial ischemia. Ischemia is represented by ST depression. ST depression, widespread ST depression. You can see there is ST depression, ST depression. Most of the leads there is ST depression, but in case of AVR there is ST elevation. In case of AVR, there is ST elevation. So most of the leads represent ST depression. Only AVR represents ST elevation. It is called subendothelial ischemia, and it also represents left main coronary artery stenosis or proximal LAD stenosis, severe triple vessel disease. So, in case of left main coronary stenosis or proximal LAD or severe triple vessel disease, the findings is subendocardial ischemia, that is represented by ST depression in most of the leads and ST elevation in case of AVR. Now the acute pericarditis. Acute pericarditis, in case of acute pericarditis, we can find this concave ST elevation, and there also may be PR segment depression. You can appreciate PR segment depression here, and there is also widespread concave ST elevation. This is concavity upward. This is concavity upward. So, concave ST elevation. In case of myocarditis, the findings is sinus tachycardia. You can see the rate of the ECG is increased approximately 150 beats per minute, and there is also P wave is present. So it is sinus tachycardia. So myocarditis is represented in ECG by sinus tachycardia. Now the pericardial effusion or cardiac tamponade. What will be the ECG findings of pericardial effusion or cardiac tamponade? First of all, low QRS voltage, tachycardia, and electrical alternance. You can see in this picture, this is the low QRS complexes. You can see the QRS complexes is small. Amplitude of the QRS complex is small. So low QRS complexes, low QRS complexes. There is low QRS complexes, and also there is tachycardia. You can count the rate approximately 120 beats per minute. And there is also electrical alternance. What is electrical alternance? You can appreciate the length of this QRS complex is relatively larger than the QRS complex, second QRS complex. Then the length of the third QRS complex is relatively larger than the fourth QRS complex. This is called electrical alternance. That means one large, relatively larger QRS complex is followed by one relatively smaller QRS complex, and so on. So, this is called electrical alternance. Now, the sinus arrhythmia, this is normal variant in young people and in case of athletes. Uh, how can you diagnose sinus arrhythmia in ECG? Sinus arrhythmia is appreciated by irregular peer interval. Irregular peer interval, you can appreciate irregularity in peer interval here, but P wave is present. P wave is present. So this is sinus arrhythmia. When P wave is absent and there is irregularity uh, of peer intervals, it is AF, atrial fibrillation. That means in case of atrial fibrillation, there is irregular rhythm. PR interval is irregular with absence of P wave. But in case of sinus arrhythmia, there is irregularity of PR intervals, but P wave is present. Now, the sixth sinus syndrome due to SA node dysfunction. And the causes of SA node dysfunction includes fibrosis, ischemia, or autonomic dysfunction. You can appreciate there is no P waves here. So there is a P wave which is conducted, causes a normal QRS complex. P waves followed by QRS complex. P waves followed by QRS complex. But suddenly there is no P. This is called sixth sinus syndrome. That means the SA node is injured or there is a lesion in the SA node. So SA node occasionally cannot produce a impulse. Now, sinus bradycardia. Uh, the heart rate is less than 60. You can count. Heart rate is obviously less than 60, and POV is present. So, this is sinus bradycardia. And now, junctional rhythm. Junctional rhythm is a narrow complex tachycardia. You can appreciate the QRS complex is narrow. That means less than 3 small squares. So it's narrow complex, and the rate is more than 100. So there is tachycardia. That means it is narrow complex tachycardia, and also there is retrograde P wave. You can see the P waves. P waves are retrograde or inverted here. And there is also short peer interval. You can appreciate short peer interval here, less than 3 small square. Now, junctional bradycardia. There are different types of junctional rhythms. Junctional bradycardia when the heart rate is less than 40. When the heart rate is 40 to 60, this is called junctional escape rhythm. When the heart rate is 60 to 100, it is called accelerated junctional rhythm. And junctional tachycardia is represented by heart rate more than 100 beats per minute. Now the AVNRT, atrioventricular nodal reentrant tachycardia. What is the mechanism of AVNRT? You know that the lesion in the myocardium uh, causes slow pathway in the myocardium, and the viable myocardium causes fast pathway. So this is the slow pathway and this is the fast pathway. When the myocardium is injured or when there is a lesion in the myocardium, the impulse passes slowly through the injured myocardium and it causes a slow pathway. And this is the first pathway. When impulse passes through this pathway and reaches here, it can travels through this fast pathway and reaches here and goes down. After passing one impulse, the first pathway goes into ERP stage. That means end repolarization potential. Goes into end repolarization potential stage, and in this stage, this first pathway is unable to receive another impulse from here. So the second impulse, which reaches here, cannot enter into the first pathway. It enters into the slow pathway, goes down through this pathway slowly, and eventually reaches here. When it reaches here, the ERP stage of the first pathway ends, and now the first pathway is ready to receive another impulse. So the impulse which is traveled through this slow pathway enters into the first pathway, and then it goes into the slow pathway again. So these occurs repeatedly, and it causes AVNRT, that means atrioventricular uh, nodal reentrant tachycardia. What are the ECG features of AVNRT? You can see the regular tachycardia, that means the heart rate may be 140 to 280 beats per minute. You can appreciate tachycardia here, and this is there is also narrow complex QRS. That means the weight of the QRS complex in three small squares, that is called narrow QRS complexes. So this is also narrow complex tachycardia, and POFs may be present or maybe inverted also, or maybe buried within the QRS complexes, or also can be present after the QRS complex. Now, ECG features of SVT. This is the ECG of SVT. In case of SVT, this is also a narrow complex tachycardia. In case of SVT, there is no P wave. If there is P wave and the rhythm is regular, it will be an ECG of sinus tachycardia. In this ECG, there is no P wave. These are the T waves. So there is no P waves, and the rate is more than 100, obviously more than 100. The rate here is 150 beats per minute. So this is an ECG of supraventricular tachycardia. Supraventricular tachycardia is represented by narrow complex tachycardia. That means QRS complex is less than 120 millisecond or 3 small squares. P wave is absent, and the rhythm is regular. That means constant RR interval. There is constant RR interval. So three important points. Number one, narrow QRS complex. Number two, constant RR interval, and number three, P wave is absent. Ventricular tachycardia, ECG features. You can see that here QRS is wide, that means more than 3 small squares, and caption beats or fusion beats may be present. You can appreciate the QRS is wide, obviously more than 3 small squares, and these are the capture beats, and this is the fusion beats. These are the fusion beats, and you can see the morphology of the QRSs complexes are same. So this is called monomorphic VT, and when the morphology of the QRS complexes are not same, that you can appreciate here the amplitude of the QRS complex is different. Amplitude is different. Here the amplitude is large, but here the amplitude is small. The amplitude of QRS complex is large here and small here, so this is not constant amplitude. This is called polymorphic VT. It is also called Torsades de Pointes. And what is fusion bit, and what is capture bit? Capture bit, this is the capture bit, this is the ventricular tachycardia, this is the capture bit. That means this bit contains POF, normal QRS complexes, and followed by TOS. So this beat is, or this impulse is generated from the SA node, so which is captured by the ventricle. So this is the capture beat, and this is the fusion beat. Fusion beat is the combination of the ventricular impulse and the normal impulse. This is the fusion of ventricular impulse and the normal impulse. So it is called fusion beat. Ventricular impulse and normal impulse fuses and created this type of fusion beat. And this is the capture beat. When the morphology of the QRS or amplitude of the QRS complexes are constant, it is called monomorphic VT. When the morphology of the QRS complex is not constant, that means the amplitude of the QRS complex is variable, it is called polymorphic VT or Torsets de Pointes. Now the non-sustained VT. Non-sustained VT lasts less than 30 seconds. So what we can find in an ECG of non-sustained VT, we can find premature ventricular complexes, that means PVC. These are the PVCs. These are the PVCs, premature ventricular contraction. Premature ventricular contraction. When this premature ventricular contraction are more than 3 in number, which is obviously consecutive. You can see here there are 1, 2, 3, 4, and 5. 5 consecutive PVCs. So it is called non-sustained VT. More than 3 consecutive PVCs can be found in case of non-sustained VT. It is self-limiting, no treatment is required here. Now, in case of void complex tachycardia, it may be a case of VT or maybe a case of SVT with aberrant conduction. How can we differentiate this type of dilemma? We can use Brugada criteria to differentiate the VT and the SVT with aberrant conduction. These features is suggestive of VT. That means absence of typical RBB or BB or LBBB morphology. That means presence of RBBB or LBBB morphology indicates SVT with aberrant conduction. Absence of this typical RBBB or LBBB morphology represents VT. And there may be extreme axis deviation. That means negative deflection in lead 1 and also negative deflection in lead 2 or AVF. QRS complex should be more than 160 millisecond, and there may be capture beats, there may be fusion beats. That means capture beats or fusion beats may be present in case of VT. So when we can find these features, that means absence of typical RBB or LBB morphology, extreme axis deviation, very broad QRS complexes more than 160 millisecond, capture beats or fusion beats. These features are very suggestive of ventricular tachycardia. When these features are not present, it may be a case of SVT with aberrant conduction. That means SVT with bundle branch block, either LBBB or RBBB. So, in case of SVT with aberrant conduction, RBBB or LBB morphology is present. In case of VT, there is no RBBB or LBB morphology. Now, the ventricular fibrillation. This is the ECG of ventricular fibrillation. You can see the fibrillatory waves. You can see the fibrillatory waves here, fibrillatory waves here, fibrillatory waves here. So this is the case of ventricular fibrillation. R on T phenomenon. R on T phenomenon, which causes torsade de pointes, and subsequently it causes ventricular fibrillation. This is the ventricular fibrillation. This is the ventricular fibrillation, and this is the ECG of torsades de pointes. This is the ECG morphology of torsade de pointes or polymorphic VT. Polymorphic VT. You can see the amplitude of the QRS complex is variable here. Amplitude of the QRS complex is variable here. So this is torsade de pointes, and this is the ventilatory waves. This is torsade de pointes. This is ventilatory wave. What is R on T phenomenon? In case of VT, when we give shock, when the energy we, when the energy is given without synchronization, it can cause R on T phenomenon. That means the energy put on the R wave, T waves, and it causes polymorphic VT. This is the monomorphic VT, and we gives energy on the T wave without synchronization, so it causes polymorphic VT, and this polymorphic VT or torsade de pointes eventually causes VF or ventricular fibrillation. Now this is the findings of atrial fibrillation. The most common presentation is irregular rhythm. That means the R interval is irregularly irregular, and P wave is absent. Now you can see here there is irregular rhythm. That means the RR interval is irregularly irregular, and there is no P wave. So this is an ECG of atrial fibrillation. And in case of atrial flutter, there is sawtooth pattern. This is the sawtooth pattern. You can appreciate sawtooth pattern in case of ECG. Now, hypertrophic obstructive cardiomyopathy. You can see an ECG of HOCM. What are the findings in this ECG? You can appreciate deep, narrow, dagger-like Q waves. Deep, narrow, dagger-shaped Q waves. Here, you can appreciate deep, narrow, and dagger-shaped Q waves. These are the most important findings in case of HOCM. And arrhythmogenic right ventricular cardiomyopathy. In case of arrhythmogenic right ventricular cardiomyopathy, we can find epsilon wave. What is the epsilon wave? Epsilon wave is the terminal notch in QRS complexes. Here we can find this the terminal notch here, and also here. There is a notch here. There is a notch here in the lead 2 also. So these are the epsilon waves, and these epsilon waves represents arrhythmogenic right ventricular cardiomyopathy. Now the Brugada syndrome. The ECG findings of Brugada syndrome includes convex ST elevation. This is the convex ST elevation. Convex ST elevation followed by T wave inversion or negative T. That means convex ST elevation more than 2 millimeter in lead V1, V2 or V3, followed by T wave inversion. These findings represents Brugada syndrome. Brugada syndrome ECG patterns may be of three types: type 1, type 2, and type 3. In case of type 1, there is convex ST elevation followed by T wave inversion. In case of type 2, there is saddleback shaped elevation, and this elevation is 2 millimeter, that means more than 2 small square, and followed by a negative T wave. Also, there is no negative T wave here. There is in type 1 there is negative T wave, but in type 2 there is no negative T wave. There is only shadow back shift ST elevation is present, which is more than 2 millimeter or 2 small square. In type 3 Brugada syndrome, there is also shadow back shift ST elevation, but less than 2 small square. And among these types, type 1 is of high risk, type 2 is of intermediate risk, and type 3 is of low risk. Low risk for Brugada syndrome. Now, WBW syndrome. WBW syndrome is represented in this ECG by short peer interval. You can see the peer interval is less than 3 small square here, and the most important findings here is the delta wave. What is the delta wave? Delta wave is slurred upstroke of QRS complex. You can appreciate the slurriness of the QRS complexes here. Slurred upstroke of the QRS complex. So there is um, short peer interval and the slurred upstroke of the QRS complex, which is called delta wave. In case of type A, there is also right axis deviation. You can appreciate here in lead 1 there is negative deflection, and in lead AVF there is positive deflection. In type B, LED is present. You can appreciate here the positive deflection in lead 1 and the negative deflection in AVF, which represents left axis deviation. There also there are also slurring upstroke of the QRS complexes, and the short peer interval also present here. In case of LGL syndrome, the ECG finding is only short peer interval. There is no delta waves. You can appreciate the short peer interval here. No slurring upstroke of the QRS complexes. That means there is no delta wave. So the WBW syndrome is short peer interval plus delta wave. But in case of LGL syndrome, there is only short peer interval, there is no delta wave. Now, the AV blocks. AV blocks may be first degree, second degree, or third degree. Second degree is further divided into Mobius type 1 and Mobius type 2. Mobius type 1, that is Wenckebach phenomenon, and Mobius type 2. Now, the first degree AV block. In first degree AV block, only the PR interval is increased. Prolonged PR interval. You can appreciate here the PR interval is more than 5 small squares. So, this is the first degree AV block. In case of second degree AV block, we can further divide it into two groups that we have already mentioned. Type 1, Mobius type 1 and Mobius type 2. In case of Mobius type 1, there is progressive lengthening of the PR interval, and followed by a sudden drop of the QRS complexes. You can appreciate here the PR interval is progressively increasing, and then this P wave is not conducted. That means there is no QRS complex for these P wave. There is no QRS complex for these P waves. That means progressive lengthening of the peer interval followed by a sudden drop. This is called movie step 1. And in case of movie step 2, there is no progressive lengthening of the peer interval. Peer interval is constant, but there is occasional dropped QRS complex. This P has not been conducted, so there is no QRS complexes for these POFs here, and the peer intervals are constant. So this is MOVI step 2. And in case of third degree AV block, PP interval, PP, PP intervals are constant. R intervals are also constant, but there is no association between the P and the QRS complexes. That means complete dissociation between P and the QRS complexes. So it is complete AV block or third degree AV block. So this is a summary. When a patient presents with syncope, we can undergo an ECG for this patient to diagnose the underlying condition. In case of complete heart block, there is complete dissociation between the POFs and the QRS complexes. So there is no association between PFs and QRS complexes, or complete dissociation between PFs and QRS complexes. P intervals are constant, RR intervals are also constant. In Mobis type 2 block, there is constant pair interval with dropped QRS. Bifascicular block is appreciated by RBBB plus left axis deviation. That means left anterior fascicular block. Incomplete trifascicular block is bifascicular block plus first or second degree heart block. That means RBBB plus LAD or RAD plus first or second degree AV block. Complete heart block is represented by bifascicular block plus third degree AV block. That means RBBB plus LAD or RAD plus third degree AV block. LGL syndrome represented by short pair interval, but WPW syndrome short pair interval with delta wave. How we can diagnose Brugada syndrome? Brugada syndrome is diagnosed by ECG by convex ST elevation more than 2 millimeter in V1 or to V3, followed by a negative T wave. We have already discussed about that. Long QT syndrome. There may be a case of ARVC, that means epsilon wave can be found. And in case of HOCM, there is hypertrophic obstructive cardiomyopathy. We can find dagger shaped Q waves in myocardial leads, dagger shaped deep uh, narrow Q waves. That means um deep and narrow Q waves, which is called dagger shaped Q waves. Now, ECG findings in case of electrolyte imbalances. What are the ECG findings of hyperkalemia? In case of hyperkalemia, we can find peaked, tall peaked T waves. Tall peaked T waves is the first findings for hyperkalemia. And then, what are the progressive ECG findings or progressive changes? Widening of the QRS complexes. Wide QRS widening. So uh, we can appreciate these are the tall peaked TOFs. These are the tall peaked TOFs, which is the first ECG findings for hyperkalemia. And progressively, QRS complexes is widened. This QRS complex is wide. This QRS complex is wide. That means more than 3 small square. This is the progressive features. and this is the first appearing feature of hyperkalemia in ECG, and this is the progressive features of ECG in case of hyperkalemia. And eventually, when the uh, serum calcium level reaches more than 9, there is risk of SL or ventricular fibrillation. Um, and in this case, in this case, urgent treatment is required. And eventually, this is the sine wave. This is the sine wave which can be found in case of severe hyperkalemia. Now, hypokalemia. What are the findings, ECG findings of hypokalemia? Uh, you can appreciate the PR interval prolongation, and there may be T wave inversion. There may be T wave inversion. This is T wave inversion. This is T wave inversion, and there may be also prominent U wave. You can appreciate U wave here in this ECG. You can appreciate this is the T wave and this is the U wave. So U wave is suggestive of hypokalemia. This is the pull push effect. Pull push effect. This is one type of mnemonic to memorize the findings of hyperkalemia and hypokalemia. These are this is the findings of hypokalemia. T wave inversion. This is T wave inversion. This is the prominent U wave, and this is the ST depression. This is the ST depression. So in case of hypokalemia, we can find T wave inversion, ST depression, and prominent U wave. But in case of hyperkalemia, we can find peaked, tall peaked T waves, flattening of the P wave, PR prolongation, and wide QRS complex, more than 3 small squares. In case of hypercalcemia, ECG findings is shortened QT interval. That means this is the main ECG abnormality, short QT interval. And another important feature of hypercalcemia is Osborn wave or J wave. This is the Osborn wave or J wave. Um, what is the J wave or Osborn wave? It is a notch in the um, QRS complexes, or near the J point, notch near the J point, or notch at the descending limb of the R wave. Now, the ECG features of hypocalcemia. The most important features of hypocalcemia is prolonged QT interval. You can appreciate prolonged QT interval here, prolonged QT interval here in case of hypocalcemia. So, this is the normal ECG. This is the ECG of hypercalcemia, and this is the ECG of hypocalcemia. In case of hypercalcemia, the QT interval is uh, decreased. That means shortened QT interval. And in case of hypocalcemia, the QT interval is prolonged. So there is prolonged QT interval. In case of hypomagnesemia, there is also prolonged PR and QT interval. Now, the ECG features of digoxin effect. The important findings of digoxin effect, that means in case of therapeutic level, not in case of toxicity, we can find reverse tick mark. This is the reverse tick mark. This is the reverse tick mark, or Salvador Dali Mastasi sign. This is the reverse tick mark, or this is the reverse tick mark here. So this reverse tick mark indicates digoxin effect. When patient takes digoxin at therapeutic levels, we can find this type of features. But in case of toxicity by digoxin, we can find the ECG features may be supraventricular tachycardia or slow ventricular response. In case of hypothermia, the ECG features are Osborne wave. This is the Osborne wave or J wave, that means notching at the J point. Prolonged peer interval. Peer interval is prolonged here, and bradycardia may be present also. We can appreciate here the bradycardia. Now, the summary. In case of digoxin, we can find in case of dioxin toxicity, we can find supraventricular tachycardia, but in therapeutic level, we can find these features, that is reverse tick mark. That is reverse tick mark. So, in case of dioxin toxicity, the feature is supraventricular tachycardia. In therapeutic doses of dioxin, we can find reverse tick mark. In case of hypothermia, the important ECG feature is Osborne wave or J waves. In hyperkalemia, tall peak T, peer interval prolongation, and also QRS prolongation, and eventually sine waves. Hypercalcemia is represented by short QR interval and also Osborne wave. So, Osborne wave can be found in two cases, like hypercalcemia and also in case of hypothermia. In case of hypocalcemia or hypomagnesemia, the main ECG feature is QT prolongation. The last topic of our today's presentation, ECG in tricyclic antidepressant poisoning, that means TCA poisoning. The important ECG finding is peer interval or QT interval prolongation, peer interval or QT interval prolongation, and also QRS widening. These are the important findings we should memorize uh, due to diagnostic case of tricyclic antidepressant poisoning. Now the pulmonary embolism, ECG findings in case of pulmonary embolism. The first classic sign is S1, Q3, and T3 pattern. S1, Q3, and T3 pattern. That means S1 indicates deep S wave in lead 1 or lead 1. Deep S wave in lead 1. This is the deep S wave in lead 1. Q3 represents Q wave in lead 3. This is the Q wave in lead 3. This is the Q wave in lead 3. And T3 is this T3 indicates T wave inversion in lead 3. These are the T wave inversions in lead 3. So the classic sign is S1, Q3, and T3. And other findings, ECG findings of pulmonary embolism includes tachycardia, incomplete RBBB, and simultaneous T wave inversions in the inferior and anteroseptal leads. You can appreciate T wave inversion here. The rate is obviously more than 100, so there is tachycardia, and incomplete RBBB may be present here. Now the summary of our today's presentation. What is sinus arrhythmia? In case of sinus arrhythmia, P wave is present but irregular. Arrhythmia, in case of sinus arrhythmia, P wave is present but irregular. In case of sinus bradycardia, P wave is present but heart rate is less than 60. Sixth sinus syndrome, P wave is present. So P wave is normally conducted here, but producing a QRS complexes, but then there is no P wave. That means there is a pause. This is called sixth sinus syndrome, and then normal sinus rhythm. P wave is conducted normally, producing a QRS complex. Then eventually, occasionally, there is no P waves, and then eventually normal sinus rhythm. So This pause is caused by sick sinus syndrome. In case of junctional rhythm, POF is absent or POF may be inverted. Regular rhythm, heart rate 40 to 60. Accelerated when we call accelerated junctional rhythm. Mm, when the heart rate is 60 to 100, this is called accelerated junctional rhythm. In case of atrial flutter, sawtooth appearance can be found. In case of atrial fibrillation, POF is absent and the rhythm is irregularly irregular. In case of SVT, POF is absent and rhythm is regular, heart rate more than 150. Monomorphic VT, in case of VT, QRS is wide, but in case of monomorphic VT, the morphology is regular, but in case of polymorphic VT, the morphology is irregular. And in case of non-sustained VT, the morphology is irregular also. That means um, PVCs are present there. Ventricular fibrillation, we can find irregular fibrilatory wave. That is chaotic irregular waveform. So thank you so much for your patient hearing, and again I thank all of you on behalf of Medino Academy. Now these are the summary of ECG rhythms. In case of sinus arrhythmia, POF presents and the rhythm is irregular. In case of sinus bradycardia, POF presents present and the heart rate is less than 60. Sick sinus syndrome, there is sinus pause due to lesion in the SA node. Junctional rhythm is represented by absent POFs, regular rhythms, and heart rate is 40 to 60. When the heart rate is 60 to 100, it is called accelerated junctional rhythm. Atrial flutter is appreciated by sawtooth appearance, and atrial fibrillation is appreciated by absent POFs and irregular rhythm. Supraventricular tachycardia. In case of SVT, POFs are absent, and rhythm is regular, and heart rate is more than 150. In case of VT, the QRS complexes are wide. In monomorphic VT, the rhythm is QRS complexes morphology is regular, but in case of polymorphic and non-sustained VT, the QRS morphology is irregular. In case of ventricular fibrillation, there is fibrilatory irregular chaotic waves. So, thank you.